Good morning, ladies and gentlemen. Welcome to the Symposium on Adrenal Disorders. And we have three very important topics and three experts to discuss these three topics. First speaker is Professor Mark Gurnell, Professor in Clinical Endocrinology, University of Cambridge. He will talk to us on primary aldosteronism. Over to you.
Good morning, everybody. Thank you very much again for the very kind invitation to come and speak in this symposium. So we've just been hearing about one major problem and one epidemic, which we know a lot about. But actually what I'm hoping to persuade you in the next few minutes is we really need to take a different tack now with a different cause of another epidemic, as it were. So this is primary aldosteronism. Used to be referred to as Conn's syndrome, but I think we should call it primary aldosteronism. And what I hope I can persuade you is we now need another approach to deal with this. So here are my disclosures. So I'm going to cover four major areas. I'm going to speak to an audience which will know this, but just to highlight what the extent of the problem is that we're currently facing and what the healthcare systems now have to pick up. I'm going to talk about where we've got major shortfalls in our current clinical care, and this spreads all the way from the start of diagnosis through to treatment. I'm going to focus expressly on something we've had a big interest in, which is actually trying to change the narrative from a long-term discussion around can this be shown to be left or right adrenal into actually where in the adrenal is the problem. And then I'm going to talk about emerging alternatives to whole gland sacrifice, i.e. to unilateral adrenalectomy. And that's actually prompted, as I'll show you, by comments from patients. So how big is the problem? Well, the problem's a lot bigger than we thought it was. So we need a little bit of sorting out of the legacy of this condition. If you go back to even a good textbook like Kumar and Clark in 2008, it was still saying primary aldosteronism is less than 1% of all hypertension. So here is a quote: he who knows nothing is closer to the truth than he whose mind is filled with falsehoods and errors. This is a quote from a president of the United States. It happens to be a quote from Thomas Jefferson, who was the third president of the United States, but you might think it might resonate with a current occupant of the White House, and I'll let you decide which side of that line he sits on. The problem with PA is there's traditionally been a really low profile, even in the hypertension guidelines. And in fact, most guidelines, of course, for hypertension are actually not written by endocrinologists, they're written by others. And it's only now that it's starting to emerge. Another big problem is this just too difficult an issue to deal with? Who should we screen? Should we be screening everybody? If anybody's actually read the recent Endocrine Society update for 2025, you'll see we're now moving towards suggesting we should, and I'll show you why. Other problems: which medications should I discontinue? Do I need to do a confirmatory test? I haven't got time to talk about this today, but the headline news is going to be that the confirmatory tests are generally very, very poor. They miss an awful lot of people who they actually declare to be normal when they actually have primary aldosteronism. So in my practice, we are now diminishing the number of confirmatory tests that we do. And then there's the problem when you come to imaging. We unfortunately can't depend on CT or MRI because sometimes the adrenals will appear normal in a patient with confirmed PA, and of course we're all aware of the potential consequences of confounding incidental-omas. And then when we come to what is the standard way of distinguishing between left and right versus bilateral disease, i.e. adrenal vein sampling, this still remains a tricky technique that's only available to a high level in a relatively small number of centres. But most importantly probably is to change the thinking of people like ourselves in this room and to stop binary thinking, as I call it. Binary thinking is, does the patient have PA or not? And then if I've decided the patient does have PA, can the patient have surgery or not? And these are binary decisions which tend to be taken once. When the patient first presents, and as I'll show you, that's not always clear, and then later, actually now I've got to the point where I know you've got PA and I've done some investigation, should I offer you surgery or should I offer you lifelong medical therapy? We don't apply that binary decision making in many other endocrine conditions. We are fluid. We come back to the condition, we review it, we change our tack depending on the patient in front of us. And I want to show you that we need to think of PA as a chronic condition that we need to respond to, and also our approach at different points in the disease journey. So it's really common. You don't need me to tell you that actually it's now at least a quarter of all patients with resistant hypertension I say to my patients in clinic still, this is 5% of all the patients who've got hypertension in the UK. I am way underestimating on that, almost certainly. And in fact, there's some really nice data that shows we really are at the tip of the iceberg. And Anand Vaidya in Boston needs to be very congratulated on his work with Jennifer Brown. This is actually a beautiful piece of data, taking people with differing degrees of blood pressure, which you can see range from normal, non-hypertensives through to people with resistant hypertension. And they essentially took them off confounding medications if they were on those. They measured renin, showed that 690 of the 1,015 people in the study actually had suppressed renins. They then salt-loaded them and measured aldosterone production in the urine and showed these absolutely alarming rates of people with autonomous aldosterone production, including in the left-hand group there, the normotensive individuals. These are people who do not have high blood pressure, but these people are part of the journey to primary aldosteronism. And in actual fact, 11% of individuals with no elevation of blood pressure had clear evidence of autonomous aldosterone production, coming all the way through to the 22% in the patients with resistant hypertension. And Anand published this before the pandemic, which is essentially now to stop us thinking about this being a single point where you do or you don't have, and recognizing this as a continuum. And this is almost certainly a big factor driven by an interaction with environment and the world that we live in. So over here on this side, we have the people who definitely have hypertension, and we recognize as those having a PA. But there's a big group of individuals that we now know, as per the previous slide, who don't appear to have been diagnosed with PA, but they meet the biochemical criteria for having primary aldosteronism. So they may have milder hypertension, or they may be way over on the other side and still have normal blood pressure at this stage. And you may have met some of these patients in your clinic, because every now and again you'll see a patient who has hypokalemia but no hypertension, and you prove that they have PA. And at the moment their vasculature is coping with the aldosterone excess, and they haven't manifested that hypertension yet. So this has been proposed as having a classical scenario where we go from subclinical PA to present but not recognized, or mild PA, through to the patient who has overt PA, which is where we have spent most of our time. And Anand actually has data which now suggests that disorders of the renin, angiotensin, aldosterone system may actually underpin a large part of hypertension in the population. It may well be that variants of PA are actually a significant factor for lots of what has classically been called primary or essential hypertension. Now, if that comes to the fore, we are also going to need our Ozempic or Mounjaro equivalents, because we're going to need to know how to deal with this. And there's a clue to this previously, because some of the beautiful data done by Maurice Brown in the Pathway studies showed that actually use of spironolactone much more early than people had ever thought about actually resulted in significant improvements in blood pressure in a lot of patients, indicating that there probably was mineralocorticoid excess. Why does this matter? Well, why it matters is because at the moment, if you have overt PA, we know that your risks of stroke, coronary artery disease, atrial fibrillation, heart failure are all dramatically higher for any given blood pressure than a patient who appears to have high blood pressure without PA, even accepting what I was just saying a moment ago, i.e. primary aldosteronism is bad for you beyond just the blood pressure itself. So it has excess effects of excess aldosterone in the cardiovasculature, which is important to know about. So the problem is, if we're now facing this problem, how are we going to come about the potential pitfalls that we have in our current clinical care? And these are numerous. So this is a pathway, and this is in a relatively recently published review that we put together. This is the conventional pathway for PA that we all think about. We need to think about the diagnosis. That's the big problem to start with. Nobody thinks of the diagnosis. We then need to have to understand how to understand the aldosterone-renin ratio. Do we do a confirmatory test? Then we've got CT-AVS, and then we make this bilateral versus unilateral decision. So the problems here are that either no diagnosis at all gets made, in which case the patient has continuous exposure to high aldosterone levels. We may not have any access to high-quality AVS. We make binary decisions, as I've alluded to already. And in addition, we have fairly suboptimal medical management. Even the drugs we have, we don't use as well as we should do. And at the moment, it's all or nothing when it comes to adrenalectomy. You can either have your adrenal gland taken out or you can't. And I want to show you that we do have a way of potentially changing this. So in this article, and you won't be able to read this particular bit, but what I want to do is to focus on the fact that we were trying to highlight new areas where we need to make progress. We need to get better at the diagnostics. And this is not work that we undertake, but if you look at the work of people like Graham Eisenhofer, developing new strategies, new algorithms with AI to try and recognize the patient with PA from everybody else. And then when it comes to identifying whether a patient has got a problem in one adrenal gland or the other, we want to move people on now, so we don't just ask about lateralization, we ask about localization. And this is an important difference. Where is the abnormality in the gland? How many abnormalities are there in the gland? How many abnormalities are there in both glands? Not is it left, right, or both? And that might be superselective AVS, which our colleagues in Japan have mastered, which is an amazing procedure. But given that we can't even get good quality ordinary AVS in most centers, it seems unlikely we'll be cannulating the individual tributaries in each adrenal anytime soon. And of course, a big interest for ourselves has been molecular imaging, which I'll show you some data. But very exciting, and we just enrolled our very first patient into the international trial last week, Baxdrostat, an aldosterone synthase inhibitor, one of the new generation of drugs, which for the first time will give us a medicine, if it proves to be effective, which will actually lower the aldosterone levels as opposed to blocking the aldosterone receptor. And there are 3 of these agents in clinical studies at the moment, and that's a potential exciting new direction for medical management. But I also want to just show you new approaches potentially to how we treat the abnormalities in an individual gland in a patient who wants an intervention but might not want the whole adrenal gland sacrificing. And what I'm going to show you is thermal ablation therapy for primary aldo. So the first bit I want to talk about next is lateralization or localization. I hope I'm starting to persuade you that we need to stop binary decision making. Do you have unilateral, do you have bilateral disease? And remind everybody that actually the emerging data suggests that this is a spectrum. And with a few exceptions, perhaps individuals who have somatic mutations in KCNJ5, which is an inward rectifying potassium channel, with those exceptions, many of the patients actually have a form of bilateral disease. They do not actually have unilateral disease. They have asymmetric dominant disease. And it's enough to cross the threshold for us to declare them unilateral by conventional criteria, and then it comes back later. They always had bilateral disease. We just didn't recognize this. So we need to start thinking about patients sitting somewhere on a spectrum, and the question is, are we at a point where we can intervene on that spectrum or not? And perhaps that decision can't be made today. Perhaps that decision can only be made next year. So instead of making a decision once and then saying to the patient, that's it, you're on medicines forever or whatever, maybe we need to review that situation a little bit further down the line. So how can we actually sort out who's who? Well, I've mentioned superselective AVS, but for us, we needed a way around AVS, and more than 15 years ago, when Maurice Brown, who's now down at Barts with Will Drake and other good colleagues, was actually working in Cambridge, he and I looked around for alternatives to AVS because we could never see this unblocking the pathway, which was currently stuck at this point. So instead, we would now like to propose that PET-CT is an alternative where you can get availability of one of the many, many ligands which are now becoming becoming available on the marketplace. So this isn't everywhere yet. Some of this is still for the future. We've done a lot of work around ligands which actually specifically bind to CYP11B1 and B2, and we can turn these ligands into B2 selective ligands. Now the agent that we've used most is metomidate, which is a close relative of etomidate, and I don't need to explain to this audience the potential role of these agents interacting with CYP11B1 and B2. This is the very first patient I ever scanned, and this is the patient that got me really excited, because what we did was to turn metomidate, which actually binds B1 and B2, into a selective B2 ligand by suppressing B1 expression in a good old-fashioned endocrine way by giving a short course of dexamethasone, which we actually do for 3 days. And what we have managed to do, if you take the second panel, is show the background uptake in the adrenals on both sides, together with the tiny little nodule which is in the end of the lateral limb of this adrenal. But when we give the dexamethasone and we suppress the uptake from the background adrenal, the nodule itself is now visible. And this patient, together with a group of patients here, made me convinced that actually lateralization could become localization, because now we could see in the gland where the problem was, not just which gland it was that we were dealing with. So if you look at that bottom case there, there's a tiny little lesion on the end of the adrenal limb, almost may not be reported by the radiologist, but with the molecular imaging it's very obvious to see. I was talking to a colleague here who has collaborated with Troy Poor, who is an expert in this, and Troy came to work with us and did another very beautiful study, a prospective study in 25 patients who had AVS and metomidate, and they were able to show that metomidate was at least as good as AVS, if not a fraction more sensitive than AVS, for the detection of unilateral, as it were, conventionally diagnosed unilateral disease. And Troy did this and published this whilst we were in the middle of this big multi-center study called MATCH, which is now published in Nature Medicine and Annals of Internal Medicine. MATCH was a big study. It was a head-to-head comparing metomidate and AVS in a randomized sequence. Patients also went on to a trial of spironolactone, which we were using to try and predict response to an intervention at that stage. In this case, it was surgery. And this trial was set up so that the patients had to go through to surgery if either investigation said it was unilateral disease, even if the other one did not say it was unilateral disease. If one said it was bilateral and the other said unilateral, then the patient still went through to surgery. The only way you couldn't get to surgery was if AVS and molecular imaging pointed to the opposite adrenal. This had hierarchical endpoints, which means that first off you look at, do you achieve biochemical partial success or complete success at the end of the adrenalectomy for those who go to surgery. Then it's complete success, because that's a higher bar. Then you look at the blood pressure, partial or complete response in blood pressure or complete response. And in the total study at the end of this, we had screened 254 patients and we had recruited 169 patients into the study. And what was amazing to us was that, unlike the conventional wisdom that only half of patients could have adrenalectomy, here more than 2/3 of the patients were meeting the criteria for unilateral disease because they had two bites of the cherry. They had two investigations that could say they were unilateral, and when one of them said they were unilateral, then they went to surgery. Now, this is quite a complex picture, but what it's designed to do is to show us that actually metomidate and AVS often said the same thing, but not always. There were a significant group of patients who could only go to surgery on the basis of molecular imaging, but there were also some who only went to surgery because AVS said unilateral. And again, what we've done here is we've shown of all the patients who got to surgery, whether they met those endpoints, partial or complete biochemical, and the same for clinical, etc., judged by which modality sent them to surgery. Was it both? Was it one, or was it the other? And over here, it's a brief summary of the story at the first stage that we published when we had just around about 130 patients at that point, showed that the molecular imaging, although we couldn't demonstrate it to be superior to AVS, we demonstrated clearly that it was non-inferior, i.e. for the first time, here is the proof that molecular imaging is now as good as AVS. And the advantage of molecular imaging is a potential to open this up to a lot more patients. We've recently published the completeness of the study with 169 patients and reaffirmed the results in the metomidate is at least as good as AVS. So I won't dawdle on that. And actually, one of the nice things is that we can turn this into truly a B2 ligand. This is a patient who had two nodules, one that lit up and one that didn't light up. And one of those is a B2 nodule, and the other one is a nodule that has a bit of B1 in it, as well as the baseline nodule also having some B1. So this is the ability to make this a selective ligand for B2 by that short course of dexamethasone. Now, one of the big problems with carbon 11 is it's got a half-life of 20 minutes, which means you need to come to Cambridge and be in Cambridge before we make the ligand. So that is bound to limit it. So long story short, people have been looking for alternatives, and I've spoken to colleagues here who've also looked at the potential for gallium, and some of you may have had access now to using gallium pentaxophore, which is interestingly a PET ligand that binds to a chemokine receptor, which happens to be co-expressed where CYP11B2 is expressed. And the advantage of these ligands are that they've got a longer half-life and in some cases better resolution. But for us, we wanted a ligand that actually had a much higher resolution than gallium does, and so we chose a fluorine ligand to pursue. Now, this is a gallium pentaxophore picture from colleagues in Berlin, showing that actually you can get really nice pictures in lesions that are above 1 centimeter in size. But the problem with the gallium is the resolution doesn't go a long way below 1 centimeter, and quite a few of the nodules in PA are in the millimeter size. So it can work, But instead, we decided to make a fluorinated version of metomidate, and this is called 18F-ceto. And this is something which we did in collaboration with colleagues in Uppsala. And pre-human studies showed that this was very selective for the adrenals, and therefore this was an exciting ligand. And even more so, it had little liver uptake. And in first-in-human studies in healthy volunteers, we were able to show with the blue lines compared to many other tissues that this is an incredibly selective adrenal ligand for the adrenal cortex. And I just want to show you just how comparable this is. These are 31 patients, although this is one of 31 patients in the match extension who had AVS, metomidate, and ceto, and it is almost impossible to tell the differences between the metomidate and ceto images. So these are two different tracers given on different days, which produce almost identical molecular imaging pictures. So I'll show you another case here. This is a patient who, if I scroll through the CT scan, you'll just see as we come through the adrenals, there's an abnormality in the right adrenal there. And now I'm going to play these two together. And the only way I can tell which is metomidate and which is ceto is that the metomidate has uptake in the liver and the ceto has no uptake. Now watch these two playing alongside each other. Oops. Let's go back. I'm going to end up with it playing dual. Let's try one more time. So watch these two together, and the adrenals are almost identical, and they both show the same lesion. So we now have a fluorinated tracer, which can now be distributed from other centers, can use this tracer, that people don't have to stay with us. And we've now scanned actually more than 1,100 patients with a combination of metomidate and ceto, and this tracer is now available within the National Health Service within the UK, but we also have patients traveling from overseas for this. This is the number of cases we can do in one center versus the number of AVSs we can manage to do. This has the chance and the capacity to massively increase the number of patients. The great news with it as well is you do not need to stop mineralocorticoid receptor antagonists to scan with this ligand. And that is a big plus, because you do not need to maneuver the medicines around in the same way that you do for AVS. So here are some other exciting tracers coming through. There's some very nice early first-in-human study with 18F-aldoview made by colleagues at University College London, which is a very selective B2 ligand and doesn't even need dexamethasone pre-treatment. And there's a whole bunch of other tracers in development. So we are going to have a whole menu of different tracers available to us to potentially scan. So what I want to do in the last few minutes is to show you another thing that we've now derived from this, which is because instead of being able to say which adrenal, we can tell you where the nodule in the adrenal is. And this was actually born out of a patient who sat in the clinic one day and said, "You've told me this is a benign disease, and I have a 5 or 6 centimeter, or whatever nodule it was, I don't think it was even a centimeter, and you want to take the whole adrenal gland out for that? Why can you not just chop out that little bit of adrenal?" And adrenal sparing or cortical sparing surgery does exist, but it's technically challenging. So instead, we thought we would try thermal therapy. And percutaneous ablation is one route to doing it, but Maurice Brown and I had had conversations with endoscopists where we were working and realized that the left adrenal could actually be intriguingly accessed via the stomach, because the left adrenal sits behind the stomach. So now this is a endoscopic, ultrasound-driven, transgastric ablation, thermal ablation of the adrenals. And you can see a nice picture of the endoscopic ultrasound and the needle coming out in through the wall of the stomach into the adrenal. This was first done as a safety study, which we published in The Lancet earlier this year. This was a safety study because we had to prove that putting a hole in the stomach didn't cause major problems. These were done under GA to start with. Patients were in hospital typically for 2 days when we first started the study. We now admit the patient for a day case. They have this done under propofol. It takes 20 minutes. They eat and drink, and they go home straight away afterwards. So they go back to work the next day if they want to do so, or a couple of days later. Versus adrenalectomy, which typically, even if done well, still means usually weeks or months off work. Now, you can only do this on the left side at the moment, because you can only access the left adrenal this way. But we did not have any major consequences of this approach. This was entirely primary endpoint driven for safety, but of course we started to get an inkling of whether effectiveness was also, or efficacy was also provable. As I say, this is now down to a day case procedure. The other exciting thing is we were able to confirm we were ablating the correct nodules because we do an FNA biopsy first, and then we do the immunohistochemistry on the nodule. So here is one of my patients whose nodule was biopsied beforehand, and you can see there's no B1 expression, but there's a lot of B2 expression. And here are his images before the ablation. You can see on sagittal imaging, which is a really nice way of looking at these, that there is a very hot spot in that adrenal gland. And the beauty of this is the ablation has taken out only the nodule. This patient still has remaining adrenal tissue. This potentially, therefore, opens the door now to treating bilateral disease. And at the moment, and this is the outcomes for this patient, this is a patient who'd had years and years of blood pressure on those agents and all that potassium. He's actually in his 60s, and he's now on nothing. No medicines at all. No potassium replacement at all. So we're now in the middle of WAVE, which is a multi-center study. Bart's, Cambridge, University College London, the Imperial, Guy's and St Thomas's, and also Sheffield. And we've recruited nearly 90 patients of the 120 that are in WAVE. WAVE is bilateral treatments. We're doing the right percutaneously. That is still more of an early learning phase. It's more difficult to access the right. But the left are being done as EUS RFAs, and hopefully we'll get some proper randomized double-blind prospective study to prove that actually our inclination from the early data is correct. And this is just one patient to show you how this is really neat, because this is a patient who has two small nodules in the left adrenal gland. One nodule has a much higher reading. That's judged by something called the SUV max. You can compare it to the background on the other side, so that's the 22.4 versus the 15.8. The other nodule is about the same intensity as the background, suggesting to us that one of these is B2 and one of these is B1. So when we biopsied those, this is the B2 nodule and this is a B1 nodule. So we only need to ablate the B2 nodule, although we could ablate the other nodule. And actually at the moment, we tend to ablate both if we see two nodules because we want to be certain. So I need to finish there and just say that I think the future is potentially very exciting for PA, because actually, as we get better diagnostics, as we get better alternative medical therapies, and as we get alternative treatments such as thermal ablation, if that becomes established and confirmed as an alternative, we will have got to the point where we no longer need to say to a patient, this is what we need to do at this, and that's it. That's your definitive treatment. Off you go, lifelong medicine or not. We will be able to revisit and come back and forth. I am really fortunate to get to speak on behalf of this enormous army of people who have conducted this study. I need in particular to highlight Will Drake and Maurice Brown, who I've collaborated with for many, many years. But now we've also forged strong collaborations with the teams, with Kareem's team at Imperial, and indeed there's at UCL, Sheffield, Guy's and St Thomas's, and also our colleagues in Uppsala. And I'll say thank you very, very much for your attention. And obviously, if there's a time at any point to take questions, I'm happy to do so.
Thank you very much, Prof. Gurnell, for that excellent lecture.